Yeah, case number 3. We have a 63-year-old female. So she had angina class 3 and a positive stress test, significant risk factors. So what happened is she did echo showed EF of 60%. Significant disease. So if you see, she had an angiogram which had shown left main and 3 vessel disease. So was referred for bypass surgery. Again, now you guys may think, where are we getting all these cases? We do have a good heart team discussion. So when we have the criteria as per our OC criteria, appropriateness criteria, all that we do call the surgeon. Most of the time we take them out of the room and then they will be seen in the office, or sometime if it's really acute, they'll be in the holding area. That's where they're going to see her. So she was seen by one of our surgeons. Surgeon was still okay to do it, but patient absolutely refused having that. She did not want to have a surgery done. And then I think what also happened is she went for a second opinion, and Joe saw her in the clinic.
Yes, I saw her in the clinic.
Hi, Joe.
Discussed with her, reviewed her angiogram. Hi, Roxana. Diabetic 3-vessel disease, including left main. Obviously, the ideal strategy would be a surgical revascularization, but she was very adamant that she did not want it.
And give me a little bit about her body habitus. So morbid obesity, BMI 46. I'm sure the surgeons are a little bit reluctant with that kind of with the chest situation. Was that one of the things that she was worried about?
Well, it was some trepidation with that, but they still felt they could probably get through that. But it was more really her unwillingness to proceed.
Okay. So show us the anatomy. We see a good LV function.
So normal good LV function. Earlier you saw the first time round with the decreased LV function, complex disease. We decided we wanted to use in the first and second case. So this is RCA. Again, typical diabetic, right? Proximal is a moderate disease, but calcified, significant disease of the distal RCA. But look at her left system.
Oh.
So you have distal left main, calcified LAD, and maybe mild calcium angiographically of the ostial circumflex. Both are large vessels, okay? Look at the D1, diffuse disease, moderate size. So if you are saying anyone that should go for bypass should be her. Now, one thing the surgeon may say, but look at her distal LAD as significant disease. So many times they do double, in the sense they may put lima mid to distal, then they'll put a vein, or some of them will do endarterectomy, vein patch, and then connect something, because something had to be done to the distal LAD. So
yeah, I mean, it's not the best distal LAD, target there. Literally very diffusely diseased, and in fact, it would not be the best target. So I'm less worried about this now. I know that it's in your hands.
But let's decide beforehand, because we already learned our lesson in the first case where we went behind that diag, which actually gave us a lot of trouble, which I'm going to show at some stage, that diagonal.
So this is definitely without protection, is that dorough? This is not something you didn't even contemplate protection here, and I think no one here on this. So obviously, just tell us, you're gonna wire both circ and LAD and then image first. What is your plan?
No. So here, let us tell you something. Look at this, 95% almost subtotal circumflex. So we will wire. And like we said, angiographically, most of the calcium is left main to LAD, possible circumflex. So we have to work on circumflex first. We decided we'll do atherectomy of the circumflex first, and then we will wire both. Once we wire both, then we will do the imaging of the LAD, because we think LAD can be managed with IVL.
I see. Okay.
That's one. Going back to your question,
Let me get some insights as you're wiring. We're going to watch your beautiful wiring, but at the same time, maybe we can hear John LaSala. How would you approach this?
Yeah, I think you've got enough calcium there to use all the strategies that have been mentioned. Atherectomy, certainly, IVL, I think that's a great strategy for the left main LAD component. I don't know if this is completely off because we're just looking at the angio, but there's not as much calcium at the ostium with the circumflex.
Right.
So you may not have to do like an IVL there, but just a rotor balloon, NC balloon or specialty balloon, I think you should be able to get by with that. I agree with Dr. Keeney's strategy.
Sunil Rao?
Yeah, I mean, I think I agree with John and Dr. Kinney's strategy here. And I think I would probably just try to use a regular balloon for that circumflex and see if you can get it to crack. There might be a calcified nodule there just approximately the distal part of the left main, and I think IVL is a great strategy for the LAD here. And then you'll have to decide what bifurcation strategy to use, and I suspect that, you know, this is, most of us would probably agree it's a two-stent strategy, and I'd probably just DK crush this.
Sanjeev Sharma?
Yeah, first is rotational atherectomy from left main to circumflex, and then wire both the vessels and image both of them, and then decide about the LAD.
Yeah. I wonder, like, why didn't anyone say, why don't we image the IVUS, you know, first? Davide, what do you think?
Yeah, especially
Because we don't know if we need to do.
I mean, if the catheter doesn't cross, it's already an information. No? So I would start with the IVUS or a balloon.
Deepak?
Yeah, I like Davide's approach. I think I would also try to pass the IVUS catheter if it doesn't pre-dilate. I think IVL is a great strategy here. I think Sunil's right, a two-strand strategy would be the way to go. I'd plan that up front. Maybe because I'm sitting next to Sunil, I'd also think, you know, radial, even though it is a complex
Great.
PCI.
At last but not least, Bruno.
Yeah, maybe for the strategy, depending on the outcome of the lesion prep, for me this would be a typical hybrid approach in this situation. So the stand from the left main either to the LAD and then DCB circ, or stand to the circ and then do the LAD ostium by DCB. It simplifies those procedures very much.
Yeah, so that's when that's a really good European approach with regard to hybrid approach for a bifurcation using DCB, except our DCBs are locked up at $6,000 a piece. So, and we don't have the data yet on de novo lesions, so that would not be, I don't think that's going to be the strategy here. So Dr. Kinney, where are you? You already did everything? Because I know.
No, we changed to rotawire. One other thing I needed to tell you, why? But like, this is a complex left main procedure with RCA involvement. If someone says, I want a balloon pump used in this case, that's okay. That's maybe a right thing to do, because if there is any vessel closure, slow flow, anything that happens, it's a catastrophe. But knowing this patient with her obesity, that was not an option here.
Yeah, I wouldn't.
Yes,
and
radial fanatics will want to do this radial, but I'm still a believer.
I think her IABP and protection is you as the operator, so let's go. All right.
I think another good point to mention here, as Dr. Keeney's pointed out, is, you know, focus on the main things. I mean, you have a lot of disease here. You're not going to make this look perfect. You're not going to do that distal right. You're not going to do that distal LED, which is a 90% lesion. You may not do that diagonal. We'll see what the approach is there. But get the main things, the ones that are making this patient symptomatic, done first, and worry about the rest at a much later date.
Yeah, that's good.
Okay, good.
So what, the size of the burr is 1.5?
Yeah, 1.5. Everything went smooth, so we decided 1.5. So now the various strategies have discussed. Since the vessel that is tightest is a circumflex, right? So definitely have to take care of that first before you do anything. And in a vessel like this, trying to even image or do something can give rise to, you know, vessel closure, slow flow. So let us get at least this tightest lesion under control, and then we can image. So we're going to start burring. We did our 3 steps.
Watch that distal wire all squiggled up down below. You might
pull back the wire a little bit. So the couple of steps here, you see that?
Yeah.
Circumflex, left main to circumflex, it's Achilles heel always for, now look at that, her, you know, heart rate.
I see that there's
heart rate
you might
went down,
need a
the
pacing.
ST depressions, yeah.
You might need a pacing wire, no?
We have
A young lady, you pull the wire back a little bit more.
Yeah.
So we did not use the pacer. Oh, okay. Okay, we're going to come back. Up. Ready?
Go.
Give me a run through wire quickly.
Watch the
Fielder
wire.
and run through.
Don't lose the wire.
Go.
No, go.
Yeah.
No, what's that?
Yeah, I think it's important to point out too, while we're talking about pacing and the setting of rotoblader, obviously right corner is we used to do all of those. Now we almost never do it unless the patient goes right into it right away. We can get by. Aminophylline still works for that, 300 milligram bolus. But you can still get the need for pacing with rotoblader in very proximal circs, left mains, and when your bird artery ratio is relatively large, like it's getting up to 0.5.
Yeah. What I saw here, when the bird jumps like that, you wonder how much ablation did you actually achieve. But we'll see now with your IVUS, I guess, or if you're going to do IVUS.
It is, no, more important is what you worry here, which did not happen, which is good. It looks the same. Otherwise, you will see the artery that is 3O becomes a 6O.
Yeah, well, no, we
Let
don't
us
want
just,
that.
now we are going to wire the LAD. I was ready. And then we will get a fielder into the, and go as planned.
Sounds
So
good.
this is LAD. So what we do, a plan is that we are not going to go to the distal area of the LAD. So let us leave the wire in the mid LAD. Hopefully we'll be able to get our procedure done.
So this was a relatively
And
discrete
fielder.
circ, and so it went through pretty quick. But the nice thing is you've debulked it enough so that you don't have as much plaque shifting and things going on when you try to work on the bifurcation.
Now, the way this behaved, if someone told me that they would wanted to do, means I agree with what John LaSala mentioned, that there was not a lot of calcium in the circumflex. Maybe we could have just done, atherectomy or IVL to the both branches.
I
right?
really would like you to also IVUS the circ too, right? You're planning for
Okay.
that
No,
too.
no, we are
Yeah.
going to do that.
You want to do
Yeah,
the circ first?
Let us
I
do
feel
that.
like you're going to
Now,
learn a lot.
we have an algorithm for management of calcific lesion. There are two algorithms. I'm telling my staff there. Andrew, the algorithm for management of calcific lesion.
Yeah.
So you're going to the LAD?
We've got it.
LAD.
We've got it. It's
Okay.
here. It's up and it's for the education.
So first and foremost, that if we think the IVUS catheter, imaging catheter does not go, then you got to do upfront. Okay, good. Where is,
Yep, right
okay, we are there.
Okay.
We will go with upfront atherectomy,
Ready,
whether
correct.
it is
Okay,
rotational atherectomy or vital
show the IVUS on
atherectomy,
the
whatever
screen?
people are comfortable
Can you
with.
show us the IVUS, please? We don't see the IVUS image.
IVUS, good.
Okay.
Okay, pull back.
Okay, start to work. It's coming.
And you
Eccentric
tell
plug
them what
here.
your pull back.
It's coming. Eccentric calcium here. Once open, ostium, left main, stop it. Stop
Looks
it.
like we don't even need IVL.
So,
Huh?
I'll show you. So,
So
Let's
then,
see.
once you image, you see that? We have to understand whether it is superficial calcium or deep calcium.
yeah, so,
So if it is deep calcium and your, like you see where our LAD is, it is not tight. Those are the kind of cases you could probably do with high pressure balloon, opium balloon, cutting balloon. You don't need atherectomy. It's only the superficial calcium. Then you use your, calcium scoring using
look at
either
it.
IVUS
Well,
or OCT.
this
Now-
is the osteo LED.
now show
Okay,
us
the
the circ.
focal-
Go ahead. Go ahead. Sorry. Go
Yeah,
ahead.
osteo LED has a 270 focal calcium.
Yeah.
And
I see
once
that.
calcium is gone, but Prox LED also has some 180 eccentric calcium. So two tandem calcified lesion.
Okay,
Osteo,
okay, let me go back, osteo LAD.
yeah, so this is the osteo LED. We see the circ wire from the 10 o'clock.
Okay, left main, show me left main.
Yeah, now come a little bit back. So this is a distal left main.
Okay,
Lumen is like okay,
yeah.
but some plaque here and not much calcium here.
Okay.
Left main.
So left main is how much? So
Area,
distal left main, your cutoff is about 7 and we are getting
Distal left main,
like
there is
what,
that
4.8,
focal
5.8.
area. There's a little
Yeah,
bit of a
5.8.
focal area more than 270. I caught my eye there. So
No,
who
that's,
would do
not,
any more atherectomy here? Sunil, you see the IVUS?
I would just use a.
You would
go with balloon?
Just balloon.
John?
Okay, now go to the osteo LAD,
sure.
3.2.
Yeah, once you get up to over 2 there, you don't really need atherectomy.
You
at
don't
that
need
point.
atherectomy.
Unless you had
Anyone
really
here
severe
would do
water
any
loss.
further
Scoring or cutting balloon for the osteal.
scoring or for the, Bruno?
Yeah, me too.
You want to see some scoring. They want to do something a little bit more, but not specifically calcium modification, maybe a scoring balloon or something in that osteal LAD. What do you think? What's your strategy?
I
Dr.
need,
King?
no, I'm just making sure that is what we have to do. So show me again, is there anywhere? So it is 180. So same thing, if you are more than 3 quadrants, so this is superficial calcium, 2 quadrants for sure. Am I seeing 3 quadrants anywhere?
Yeah.
Is key.
Yeah.
Because the decision is, are we going to use cutting balloon or do we need to do IVL?
Yeah.
Oh, right there.
Of course, IVUS, so we cannot see the thickness, but the longitudinal length is less than 5. It's a focal, might be 180, might be 270. That's the osteal LAD.
So you see here, close to, 3 quadrants for sure, maybe 4 quadrants, that's what you are seeing it. But what Kiski is telling, remember we need the length also. We cannot get the thickness based on the IVUS. You need OCT for that. So you have more than 3 quadrants, which is one, and then based on the IVUS, and other one is, we think it's less than 5 millimeters. So let us go for a cutting balloon.
Well, let's hear, John, what would you do?
What do you think, Kiski?
John is
of
sort
course,
of
you try.
shaking his head.
If the cutting
John?
balloon doesn't work, you can go then step up the IVL. So.
John?
I tend to favor IVL in these. I mean, I realize you can't get the depth here,
Just
but you
we're gonna
have a
image the
length and
circ.
you have the circumferential calcium. So that you'd like to get as many fractures as possible, and I think IVL gives you that.
You want a 3-2-5?
Okay, let's go IVL then.
Well, what do
You
you,
have 3-5 then, IVL?
3-5 IVL.
Yeah. Vessel size is definitely.
Okay. 3-5. Get
Sunil?
open IVL.
Sunil?
Like I said, I'm old school. I just use an NC balloon here. I mean, it's $80 versus $4,700. I don't know. I tried an NC balloon. If that didn't work, then I think you can pull the IVL out.
Davide Capodanno,
Okay,
you
go.
just told us about calcium modification therapies.
Go
What
ahead,
would you
Kiski.
do here now?
Yeah, check the.
My first
IVS.
guess was for the angiosculpt.
Angiosculpt, okay.
Can you show the IVUS? Okay,
Go.
start to back.
This is the circumflex.
Circumflex.
It's coming.
Let's see if there's any calcium there.
Yeah.
A little bit.
Yeah. Look very similar.
That's less.
Yeah,
Good.
It's pretty.
Show the osteal
done.
circumflex.
Osteal
Yep, I'll show
circ
you.
looks like you broke up some calcium there.
Yeah, we did.
So this is
We
the distal
definitely
vein.
needed rotational atherectomy.
This is so
See that?
it's actually osteal
Yeah.
circ.
Okay.
But
So-
if you don't use all the energy on the LAD, if you're using IVL, can you use it in the circ too? Save some of the energy for the circ also. So
Okay.
Sunil doesn't get upset that we wasted so much money.
I'd probably start with the circ, actually, because I think once you deploy it, it's going to be very difficult to deliver across
Yeah.
the circ.
Okay, so.
Okay, show us. Do you need it may not, I don't know whether it will go. You know what? At least we did rota of the circumflex.
Yep.
Let's go with what we planned. Do the IVL of the LAD. If it does not go to the circ, that's okay. What do you think, Kiski? Go back to the osteal circ?
I
So
just
it's
don't
again,
think,
it's- there is a.
I'm
it's a
hoping you
calcium, but
could
it's very
save
focal.
some of the energy for the circ too.
No,
If
no,
you
we will. But the thing is, the balloon will go to the circumflex. That's why he's trying to tell you that go to the circumflex first.
Yeah,
No, what happened? Opened? Want to try circ first?
Yep.
Huh? Circ
Yeah,
or LAD?
yeah.
The
I think
issue
we do the
comes up
circ
about the
first.
sizing of the 2 vessels. If there's a disparity between the 2 and you're going to use the same balloon for each one, always choose the larger one. The reason being is that you don't really have to be 1-to-1.
We are using 3.5 to circ. Is it too big?
Yeah, you can.
We can, okay.
so you can
So
use the
what we have
3.5
seen
even though it's a
actually in
3.
at least 4 to 5 live cases that we have done to India, that when the calcium is not 3, if it's half quadrant only, that is 2 quadrants, 180 degree, and we have done IVL, we have seen a lot of hematomas.
Yeah, as I was saying, let's say, for instance, you had a 375 LAD and a 3.5 circ. You could put a 4.0 in there because you're only going to 4 atmospheres. This is not going to be a pressure-related dissection there.
Okay, go.
This is the sonic pressure waves are going to be the same regardless of
Go.
the size of the balloon.
Going up to 4 atmospheres.
We have seen the hematomas, we have seen contained perforations. Okay, ready? 4 atmospheres.
You can show Anju.
Down. Okay, go once more.
We just
We are
speak to
going with the
Anju.
suggestion. We went to circ first.
Can we see the angiogram? Yeah, there we go.
Yeah. Now it's not making the turn further down, but that's okay. Down. Okay.
I know with the hematomas that you mentioned, has that been
Go.
with one-to-one sizing of the IVL or with even
No,
if it's less?
my concern is if you see what the IFU and what the company says that even if it is 2-quadrant calcium, the so-called normal vessel will not be affected by the ultrasound waves, but that's not we have seen. So if you have 3 quadrants, 4 quadrants, good, excellent. That what I think is even the uncalcified or the opposite wall can get damaged.
Yeah.
But have you seen that even if you, let's say it's a 4-millimeter vessel, but only use a 3.5-millimeter IVL, have you still seen that type of hematoma?
No, because we go with the, when we are using IVL, one place I would definitely do is we always image and we go 1-to-1 vessel size. So definitely it's 1-to-1 vessel size, go up. And it's only 4 atmosphere, like here, even here, we are just about 4.
So I'm sitting at 4 atmospheres delivering 10 pulses.
Yeah, obviously, it's supposed to be 1-to-1, but you can get by if the balloon is a little bit larger because it's such low pressure.
Yeah. So I get your point, Deepak, that if it is a smaller vessel, that maybe you may not be able to. But if you are not 1-to-1, then I think the fact that you have to do calcium modification, it may not work. You definitely need the balloon size 1-to-1 when you're doing the IVL.
No,
Good,
I agree, but if you're
so how many
doing-
left? Yeah.
So I think
4
if you're
left.
doing roto first, that sort of changes that equation a little bit.
Okay, ready?
If you look at the registry data for IVL,
Right.
there were perforations, but they're not related to the balloon component of it with the IVL. It's the post-procedure, post-IVL, whether it's stenting, high-pressure balloon inflations in a calcified milieu. Those are the ones that can perforate, and I certainly have seen a couple of those.
Don't touch this.
Good point.
So what's the balloon for the circ? We said 3O.
We have a 3.0. 3.0 15 ounce.
It's bigger, no? 3.5. Okay, give me the, we are going to the IVL to the LAD now.
Yep.
Okay.
And I know what Roxana is going to say. Image again.
Yeah, but next time, please tell Dr. Sharma we want to see some OCT.
Okay. We have OCTs.
Appropriate, obviously, and we don't want it on
Yeah, appropriate
severe
cases.
CKD patients or stuff like that, but.
Okay, this is another thing I have seen.
Joined.
Yeah. Now, see, already. Does not go.
Well,
It's not the first time, it's happened to me many times. Now we are stuck with no IVL.
okay, maybe you just do a little pre-dill and then go.
Yeah,
Okay,
Get a 3.0 15 high.
high pressure balloon.
yeah. The message here: if you have any difficulty crossing, you
Yeah.
don't start with an IVL. You gotta don't frustrate yourself.
Don't frustrate it, yeah.
Do a prep first.
No,
Save-
this could be since it was used already in the circumflex. So that is
Yeah.
why
And
I
it's
was
not
very
surprising because it
concerned.
was used already and it's really calcific there, so let's just use the balloon.
No,
and
hold
I'm
on,
sure
hold on.
it'll go.
Oh, we could
And
have
we
used
should
a cutter.
definitely use it because we've got it open.
We have it.
You have a
Yeah,
cutter?
the analogy is if you've done balloon angioplasty in the early 90s.
I think a 3.0.
Hold on, hold on.
Hold on, don't open it.
Okay, I don't know, 3 to 5 cutter.
325.
Okay, we'll do a cutting balloon because that was what the suggestion by many people also for the LAD based on the. Let's do a cutting balloon and let's see if the IVL will go, otherwise we just stent it. Same, I think left main disease, large vessel, significant stenosis, like the discussion happened until we have data on large vessel and DES, drug
I
coated
see
balloon.
EKG changes there.
Yes, EKG changes has
Observation.
been there, consistent as soon as we finish rotational atherectomy.
I can see,
Okay,
you can
there.
see what's happening at the
Go.
bifurcation, that there's no way you can do this provisionally anymore.
10.
Yeah.
It's beginning to generate on both limbs.
This is a
Yes.
two-stent, I
Down.
think. Sorry, Bruno.
But this is AK and Roxana. I mean, when you look at the Excel data, I mean,
Down.
very clear, osteal circumflex disease,
Down.
40% failure rates.
real, right.
I mean, it's so critically important to get that right. And then the other comment I was going to make was, based on the IVUS, an old lecture that Dr. Rao gave years ago in
How
terms
far you want to
of
go? All the way
EEL
down,
to
right?
EL, if you can
You wanna
see
go
it,
cut that?
size it up.
Yeah.
And it
Oh, this is
measured,
3 to 5,
I
too
think,
big?
3.5, something
Yeah.
along
it'll be
those
okay.
lines. So a 3.5 vessel is at the very least here.
Yep. If not 4.0, I mean, it's a big circ.
Okay, someday, yeah. Yes. Okay, let me go to
Your
the,
wires in a.
So how's
small
it
vessel.
going now?
now what we are going to do is we want to decide how distally, how far we want to go. Means we are probably, so we have to stay there, stay in the LED right here, not go too distally. But look at where, in our cranial picture, right? Here. Up to the first septal, there was disease up to the first septal.
Yeah.
So we need to cover till there, so we
Your
are planning
landing
to
zone is
dilate.
just after that first septal.
Yeah, good. So it's a good sign that used cutting balloon has made its way and the lesion is yielding. Right, okay, go up here. Down. Do we just stand or anybody wants IVUS again?
Well, I'd like to see,
Go up here.
you're not going to bring that IVL back? I don't know.
To
Let's
begin
see what
with,
it
we
looks
were,
like.
yeah.
I would just stent it.
Yeah, their EKG changes and.
I mean, the way that it has yielded, I think we can just stent it.
Yeah,
Left main, you
really
want to
depends
do,
on
give me the IVL.
Depends on the
Osteal
patient's
LAD,
stability.
maybe
With
we can do the
EKG
IVL.
changes that are this persistent, I think I would just move on.
Okay. And also what we do is once we have had a good result, the only thing is I'm not happy, you wanted IVL of the, we will do IVL of the left main to osteal LAD at one spot. That's it, not going to way further down. In the circumflex, we still saw a little bit of dog bone. Whether we need to pre-dilate before we stent or we directly stent. Despite rota and so just go at one spot, okay?
Yep.
Okay, still not going.
Don't waste your time.
So 325,
Yeah,
33,
38.
38,
And the circ will be a,
325, 38,
what did we decide for the circ?
23, 35, 23,
30?
20,
No.
3020.
What is that? No, 20 cannot. Okay, now,
Yep, go ahead.
good. 30?
Yeah, 30.
Based on your imaging, what are you talking, Kiski?
Yeah, so vessel size 3.5, but eccentric on the console, so it's not a healthy
Okay,
landing
30.
zone.
No, I know. Circ, we will go 30
3023,
Yeah, that's
Yeah.
safer.
and a 3538,
for the
325, 38.
Dr. Keeney, are we sure we can cross that circ in that mid-segment there, which is eccentric and calcified? I'm worried that the stent may get hung
With
hung
the
up there.
stent, you mean you have to pre-dilate first?
I
Okay,
would
that's-
probably
that's a good
pre-dilate
question.
that area first.
You have a 3 or 12 balloon? You're right, because even the IVL never crossed.
I'd probably take a note, an NC balloon there. You know, one of the things, of course, is
You want a 35 for the LED?
the vector is going to be towards the ventricular
Ventricles.
side, right? So that's exactly
3
where the
to 5,
lesion
no?
is. So that's
They're
going to
not
be
right.
Would you change wires?
Kiski,
Dr.
LED
Vassell?
3 or 3.5?
I mean, on the plug, so 3.5 is kind of aggressive, so 3.25 or 3.0 is safer, I think. But
I think 3 or maybe safer.
yeah, but point is the left main is 4-5 vessel. So
Yeah.
if you cross over,
3 to 5 you found? 38? No? Down. Okay, then 3-0.
No, 23.
so the key is left main is 4-5 vessel. Left main is 4-5 vessel.
Huh?
Left main is 4-5 vessel.
Go for here. 4-5.
Yeah.
Wow, down. Okay, so the circ has expanded well.
And then
Give us-
one trick is after you've
What's
used
the
this
strength you
balloon
have?
and it's unfurled,
No 3.
pull it back into the
synergy.
guide
What
and
is
then go back
synergy?
down.
Go to Zion.
See
No,
if that core
Zion.
profile crosses at this point.
Okay, so,
Yeah, 3 or 23. And a 3 to 5, 38, quickly. So show the mini crush left main on the side.
yeah, we have it.
Give me, so we're going to the circumflex, the most difficult.
Yep.
So,
And then we are going to put a 3 to 5 because now Kiski is saying left main is almost 4-0.
yeah, exactly. So I'm worried
And
that
the
you're undersized.
LED is not 3-5 distally.
This one on that.
I mean, we didn't cross that set also.
Oh, okay. So you go low pressure, okay? So what you can do is we deploy it low pressure so you don't want distal edge dissection. And then proximally we will do the proximal optimization of the left main with the 4-0 actually, with the very high pressure. So despite that, you see that? We will go. Okay.
There you go.
Yeah, it went further down.
That's good work.
Yeah.
So everybody agree with this mini crush? I didn't hear anyone wanted to do DK crush, Davide Capodanno.
Yeah, because of the angle and because this is the most difficult, of course, to pass through. So I think I would have started with the circumflex as well. And tap or mini crush are options here.
With the size of-
Sunil?
Yeah, I think that the big advantage of that mini crush is that it preserves your side branch. So once you get the proximal sort of micro part of the stent crushed, and then you do your first kiss, then the side branch is preserved. You can work on the main.
We see it beautifully demonstrated on this Bifurcate app.
I have circ.
Dr. Sharma? You?
Yeah,
Yes, Sanjeev.
Yeah, Dr.
Not the other Dr. Sharma.
Okay,
You,
sometime.
Sanjeev.
Dr. Kenny, for
Okay, no, no.
LM to LED, I would like to have a 3-5-38 stand and deploy a little lower pressure if you feel the LED is 3.25, because the 3.25 expanding left
Sometime.
main for the 4.5 is too big. So better to go with the 3.5
Where's the circle?
atmosphere and then optimize the LED with the 3.25 and left main is
Okay, no.
Dr. Kinney, tell me exactly what you're doing. No, it's a good point.
So, no, we are, you're seeing we're
Show
placing the
us and
stand.
talk through your work here, because we want everyone
Yeah,
to...
we are, you see that? We are placing the stand optimally.
Yeah,
Okay, ready? Go.
it's the marker, you see
So
everybody?
you see that, you see that very well, everything looking good, but we will answer Sanjeev Sharma. Yeah, go for the circ, go with the circ. We're going up with the circ. First is the circ, you see that? It's going up,
Sometime
Good.
soon. Yep.
yes. Go, 12, 14, yeah, good.
14.
Down.
It's a little bit
Now what we are
angulated,
going
and
to
I
do is
don't
go
see
for a
a
second
very
time.
good dilatation
Yeah.
there, but it may be the fluoro.
Good. And then we are going to have the, fluoro, you don't see it well. Good. And now we are going to do is remove that,
It's not,
confirm. Now, he was
the
saying go
patient
with
is
the
obese, I
3-5, low pressure, which is also
I
doable,
don't see
but
it. You see it?
we took 3 to 5.
can tell you
He's
what
worried about 3 to 5 becoming 4-5 in the left main.
So we've modified this technique by, after you deploy the side branch stent,
Yeah,
take the balloon back 2, 3, 4 millimeters and then do a high pressure then.
Yes, yeah,
to
So
be
you
done
expand
with
then.
it.
go.
And then you can leave the balloon out proximal to the stent in the main vessel. Deploy the main stent,
Down. No,
and then do one more low pressure inflation on the side branch stent.
Mm-hmm.
This prevents the closing the door that takes place, so
Yeah,
jail
that's
stent balloon.
interesting.
Okay, now get us a 8
sort of a
millimeter.
mini
We
DK
actually, the exact pot balloon don't exist. 8
It's the
millimeter.
La Sala
fluoro.
modified
Yes.
crush.
Yeah, it is.
Nice. I like
I mean, so
that.
this isn't classic, right? I mean, here they've crushed the side branch stent, which is a circumflex with the LED stent. I mean, traditional DK crush, you'd crush it with a balloon, kiss balloons, and then stent the main branch.
Modified because it saves you a lot of time.
Yeah.
The downside
And
is,
and effort.
yeah, you got to cross the side branch, which again is easier if you do the classic sort of kiss, the first kiss.
You can do the pod after this and usually get back in with this technique.
No, we know. They're just describing decay crush steps. I know. They know we're doing mini crush, and mini crush is being shown in the side.
I still struggle sometimes in trying to really nail that osteal circumflex with the stent.
Okay. He
Particularly
wants,
if
he
you have
wants to
trouble
be
getting
very
it
clear
in,
that we did mini
and you
crush,
blow it up,
not
it goes
decay
in the
crush.
same
Look at that
direction you were
beauty.
pushing.
Look at that
You kind of
beauty.
lose the
Okay, now get us
marker.
yeah. 408, then we're going to recross kiss.
2.0 mini track.
I don't know, it may go. 3 or 12 high pressure balloon.
So
We are
now-
going to do
After the
the
cross.
proximal optimization and then we will cross and kiss. You still want us to show the steps or you want to go to the
Yeah,
other
I
side?
think so. I don't know, is Dr. Sharma ready? Because we really need to go to
Ready,
the.
ready,
Okay,
ready,
let's
ready,
go to
ready.
Dr. Sharma, come back
Go.
and show us your final images. Good?
Okay, part, recross, kiss, all went easy. We call it boom boom. And now we are doing imaging. Show the circumflex already.
Yep.
So you
Circumflex,
recrossed,
you see?
you recrossed, you kissed, and now we've got,
First, a proximal optimization, because there will
Yes.
definitely is a 3 to 5 stent in the 4-5 vessel. We went 4/20 atmosphere with that 8 millimeter balloon. Then recross.
it
We have
seems
a
to me you have more
3/20 in the
dilatation to do
ostium.
there, just looking at that.
And then
Quickly.
now we are going to the LAD IVUS. Let's see if it's going. No?
Yeah, just osteal circle is kind of elliptical shape, and area-wise it's like around 4.3.
No, osteal circ, we got 5.2, no? MSA?
No, this looks to me that needs a little bit more dilatation, Dr. Kinney.
Where, no?
Yeah.
Show me.
That looks like a keyhole.
Yeah, only the osteal circle. Other part is very expanded. Left main expanded, block circle expanded. Just the osteal circle
Sir, osteal what?
is kind of 4.5. around
Osteal
4.5.
circ needs more dilation. Everybody agree?
Okay, good.
Good.
Now it is,
Okay.
Kiski, go back. Measure
Yep.
it.
Okay.
Pull back on this
Pull
first.
back.
Okay, do the LAD pull back.
Yeah,
Okay.
here's where IVL may have made life a little easier to have done
It's
it.
coming.
Yeah.
Yep. Block LED. And osteal LED. Yeah. This
is good.
This much better. Yeah.
looks
This
good.
much
Yeah,
better.
left
LAD
main
looks
good,
good.
everything
It's
is
the
good.
osteal circ only, as usual.
Yeah.
No, I go back to the,
So
okay.
this is the left main and osteal LED. There's some constant behind, but area-wise it's 6.1. So optimal area, I think.
Need to
Okay,
work
go
on
back
the
to
left main.
osteal
Left main
circ.
also needs
sure.
dilation.
I mean, I don't think you
Left
can
main needs a
do
high pressure
anything
dilation
more.
with 4.5.
The
LM.
LAD,
Left
That's it.
main.
left main,
Left main also
okay.
needs dilation.
Yeah, that needs help there. Okay. What's the plan, Dr. Kinney, before we go to Dr. Sharma? Because I got to move on to the guidelines.
Nothing, we'll go back to, we went with a 3-0, right?
Yeah.
High pressure.
Well, you
We'll
obviously
go 3
need
to 5
the-
high pressure, that's
Yeah.
it. And you have to kiss again.
Okay.
And then we'll image.
All right, sounds good.